Welcome to Section 6 in Pulmonology. In this section, we will be talking about VQ mismatch, respiratory centers and control of breathing, chemoreceptors, bronchodilation and bronchoconstriction, and finally, we will be talking about an integrated approach to pulmonology physiology questions. So let's get started. So let's talk about VQ mismatch overview. So ventilation V to the alveoli and perfusion to the alveolar capillaries, Q, should roughly match up to allow proper gas exchange. In normal gas exchange, carbon dioxide exits and oxygen enters. And when talking about VQ mismatch, it's important to recognize that the lung is divided up into three zones. You have the apex at the top, the middle section, and the base. So zone 1, 2, and 3. In healthy adults, this is the case. Ventilation and perfusion are greatest at the base of the lung, zone 3, and lowest at the apex of the lung, zone 1. So let's draw this out. So here are two lungs. We have the heart, pulmonary artery, and we have the trachea here, and the bronchi reaching the lungs. So I'll label those really quick. We have the pulmonary artery. So it's through the heart and the blood that the lung is perfused, and it's through the airways the lung is ventilated. So let's divide the lungs into three zones. So we'll have 1, 2, and 3. And due to gravitational forces and the low pressure with which the right ventricle pumps blood into the lungs, perfusion Q is highest in the base of the lungs. So we'll draw a big Q for perfusion and two up arrows, signifying the high perfusion to this part of the lung. Whereas at the top, again due to gravitational forces, perfusion Q is very decreased. So now let's talk about ventilation. Similar to the blood, the gas entering the lungs is pulled down to the base of the lungs due to gravitational forces. So we'll see high ventilation in zone 3. However, I'm not going to draw a second arrow because the gas is not as heavily pulled to the base of the lung as the blood, but it is still increased at the base. And same situation with the apex of the lung. Ventilation will be a little bit decreased at the apex, but not to the degree that perfusion is decreased. So if you look at the ratios, you can see that V is higher than Q in the apex, so there is an increased ratio. Conversely, in the base, Q is much higher than V, so the ratio is decreased. This is normal physiology. It's not super important to fixate on these zones. What is important to know is that normal physiology, as explained here, results in an arterial partial pressure of oxygen of around 100 millimeters of mercury. So PaO2 is roughly equal to about 100 millimeters of mercury. And we're used to that. We're familiar with this number. And the point is, feel comfortable with the fact that this distribution and this physiology combined results into 100 millimeters of mercury for the partial pressure of arterial oxygen. The reason we care about VQ ratios is because if we see the arterial pressure of oxygen decrease below this number, such as in a hypoxemic patient, we must at least consider that something pathological is going on and that potentially ventilation is a problem or perfusion is a problem. It's not always the case in a hypoxemic patient, but we must consider it. So I'll erase this half of the diagram. I'm just going to quickly draw an alveolus and a capillary. So we have ventilation and perfusion, and overall this will lead to a partial pressure of oxygen of around 100. So we can then start to mess with things and we can say, what if perfusion was blocked, like with a pulmonary embolus, then what would happen to the VQ ratio? Well, Q would be eliminated, so you would be left with a VQ ratio that's essentially infinitely high. We'll just say increased. And this would create a lot of dead space. And recall that dead space simply refers to gas that enters the lungs and the alveoli but does not participate in gas exchange. Okay, so let's do this again. What happens if the ventilation is blocked with something such as pneumonia? So we'll just fill the alveolus with fluid. Then the VQ ratio, you would see decreased V, and so the ratio would be decreased. and this creates something called pulmonary shunting. And we will discuss this more on the next slide. The point is that both of these situations would both cause decreased arterial pressure of oxygen, making the patient hypoxemic. So let's talk briefly about pulmonary shunting on a new slide. So here's the heart, and here's the aorta, and the pulmonary artery sending blood to the lungs. And then we have the vena cava, which returns blood to the heart. As you recall from the lecture on gas exchange, we discussed a right to left shunt. So an example of a right to left shunt is Eisenmenger syndrome. So let's say this patient here has a ventricular septal defect. So blood is actually returning to the heart from the vena cava and then moving from the right heart to the left heart. And then this deoxygenated blood would then enter systemic circulation without ever becoming oxygenated. And this would ultimately lead to a partial pressure of arterial oxygen that is decreased. So the patient is hypoxemic. Now, a pulmonary shunt is very similar to this right to left shunt in the heart. So I'll draw an alveolus up here and a capillary. Now, if a patient has pneumonia, again, we'll fill the alveolus with fluid, then their ventilation will be quite low, so decreased V. However, their perfusion, Q, it will flow as normal. That means that deoxygenated blood entering the capillary will not receive oxygen as it should, and it will remain deoxygenated. So we have decreased oxygen content entering the capillary. You'll have low oxygen content exiting the capillary. So this deoxygenated blood will then return from the lungs into the left atrium, and then into the left ventricle, and will then enter systemic circulation and contribute to hypoxemia, decreased arterial pressure of oxygen. Now, it's important to know that when a part of the lung is not being well ventilated, such as in this pneumonia patient, the pulmonary arteries will recognize this and will constrict. This is called hypoxic vasoconstriction. This essentially causes more blood to go to the parts of the lung that are well ventilated. And this hypoxic vasoconstriction somewhat minimizes this hypoxemia that we're talking about. So now let's talk about some of the causes of VQ mismatch. Now, VQ mismatch is one of the three main causes of increased AA gradient. And we discussed this in the gas exchange lecture. And there are three main causes of increased AA gradient. As a review, there's VQ mismatch, a right to left shunt, and diffusion abnormality. Now, focusing on just the ventilation part for a second, there are the main causes of decreased ventilation are pneumonia, which blocks air from entering the alveoli, and a foreign object can also block air from entering the alveoli. Asthma does the same thing, as well as chronic bronchitis. As for decreased perfusion, one of the main things that can cause decreased blood flow to the alveoli is a pulmonary embolus, which we just discussed. Now let's do a question. So let's say an elderly woman has lobar pneumonia. What will happen to shunting? So we'll say here is an image of a lung, and if this patient has lobar pneumonia, we will say that this area is filled with fluid. What will happen to pulmonary shunting in this region? So let's zoom into an alveolus in this region. And we also have the capillary. Now with pneumonia, as we discussed before, the alveoli are filled with fluid, so they are poorly ventilated. So the pressure of oxygen in the pulmonary vasculature will be decreased, which makes sense. There's decreased oxygen content. Therefore, the deoxygenated blood will return to the heart without obtaining oxygen. And this is called shunting, which we just discussed. However, as you recall, hypoxic vasoconstriction will occur and will allow more blood to go to the regions of the lung that are well ventilated. So the blood will actually flow more to these regions in this part of the lung. In other words, this patient is experiencing a shunt which decreases oxygenated blood, but the hypoxic vasoconstriction will actually reduce this effect and reduce the hypoxemia. To take this a step further, what will happen to the VQ ratio in this patient? So we know that the V for ventilation will be decreased significantly as a result of the fluid in the alveoli, and that perfusion Q will be decreased a little bit from the hypoxic vasoconstriction. However, we can mainly think of ventilation being primarily decreased and perfusion to the lung staying relatively normal. So we can safely say that the VQ ratio has decreased, which is causing the hypoxemia. So now let's talk about control of breathing. So the respiratory control center is the brainstem, primarily the pons and the medulla. And the signals from the brainstem stimulate the respiratory muscles, for example, the diaphragm or the intercostal muscles to expand the thoracic cage. Now the brainstem maintains normal unconscious breathing. However, it can be acted upon by peripheral chemoreceptors, which are the aortic and carotid bodies, and it can be acted upon by the central chemoreceptors, which is the ventral medulla. But there's also conscious stimuli that can alter the brainstem via the cerebral cortex. So let's draw this out. So let's first draw the respiratory centers in the brainstem. So this includes the pons and the medulla, and together they control respiration by stimulating the intercostal muscles and the diaphragm. So we'll draw the diaphragm, thoracic cage, and this respiratory control center will control these respiratory muscles. Now I am intentionally drawing the nerves exiting the medulla, not the pons, because this is actually what happens. The medulla can stimulate exhalation or inhalation. The pons is considered a part of the respiratory center because it acts upon the medulla. There are two specific centers you need to be familiar with: the apneustic center and the pneumotaxic center. The apneustic center stimulates the medulla to increase inspiration. The pneumotaxic center does just the opposite. It inhibits inspiration by the medulla. The medulla can receive inputs from the cortex, which is how we can voluntarily alter our inspiration and expiration. So we'll just draw the rest of the brain up here. The medulla can also receive inputs from the peripheral chemoreceptors, specifically the aortic and carotid bodies. So here's the heart, the aorta leaving the heart, and we have the carotid bodies and aortic bodies. Recall from chapter 2 that cranial nerves 9 and 10 send signals to the medulla. We will discuss what stimulates these peripheral chemoreceptors more in a moment. Now the medulla itself contains what are called the central chemoreceptors. These are located in the ventral part. So we'll say right here is the peripheral chemoreceptors, and right here are the central chemoreceptors. So let's first talk about central chemoreceptors. Now the central chemoreceptors in the medulla, as we mentioned, test the CSF. It does not test the blood. And it's stimulated by increased acid concentration in the cerebral spinal fluid. And the increased acid will then stimulate the chemoreceptors, and this will lead to increased respiration or increased stimulation of the respiratory muscles. So let's draw this out really quick. So here are the pons and the medulla has chemoreceptors. And these chemoreceptors are sensitive to increased concentrations of hydrogen ions or increased acid. It is also indirectly stimulated by increases in CO2 concentration. CO2 can actually cross the blood-brain barrier. And recall the equation: CO2 plus water can form hydrogen and bicarbonate. And it's via this equation that the CO2 will actually indirectly stimulate these central chemoreceptors, because CO2 can cross the blood-brain barrier, enter the cerebral spinal fluid. Once there, it can shift this equation to the right, thereby increasing acid content, and this acid will then directly stimulate these central chemoreceptors. It's important to recognize that hydrogen does not readily cross the blood-brain barrier. However, CO2 is able to cross. So the point is that increased CO2 can increase hydrogen, which will stimulate the central chemoreceptors. Once stimulated, the medulla will then send signals to the respiratory muscles to increase respiration. So we'll just draw the thoracic cage, intercostal muscles, and the diaphragm. And this increased respiration will work to decrease the level of carbon dioxide in the blood. Now let's talk about the peripheral chemoreceptors. Now the peripheral chemoreceptors actually test the blood, unlike the central chemoreceptors. And they are stimulated by increased partial pressure of carbon dioxide or decreased pressure of oxygen. In other words, hypoxemia stimulates the peripheral chemoreceptors. And once stimulated, they will increase respiration by sending their signals to the medulla, and the medulla will cause this increased respiration. Also, increased hydrogen concentration or acid will stimulate the carotid body chemoreceptors. And it's important to recognize that increased acid really stimulates the carotid body chemoreceptors, not the aortic body chemoreceptors. And once stimulated, respiration will increase. So let's draw this out quickly. So here's the heart, the aorta, and the carotid arteries, and they send signals to the pons and medulla, and they do this via cranial nerves 9 and 10. And they are stimulated by increased pressure of carbon dioxide or decreased partial pressure of oxygen. In other words, if the patient is hypoxemic, these receptors will be stimulated, and the medulla will then increase respiration. So we'll just draw the respiratory muscles, diaphragm. The medulla will stimulate respiration. Something unique about the carotid body receptors is that they are sensitive to increased concentration of acid. In other words, acidemia can stimulate the medulla to increase respiration. So now let's talk about hypoventilation. You need to think of 3 types of hypoventilation. First is called metabolic hypoventilation. And this just means that the blood may be very alkalotic, and so respiration is significantly decreased in order to try to acidify the pH or decrease the pH. And this is called metabolic compensation. This is discussed in great detail in the nephrology chapter. The second type of hypoventilation is central hypoventilation. This means that anything within this neural circuit is damaged or dysfunctional. So for example, severing the nerves, damaging the medulla or the pons, or anything in this circuit is considered central hypoventilation. The third type of hypoventilation is peripheral hypoventilation. Peripheral hypoventilation is anything that restricts the full expansion of the thoracic cavity. So if the patient is very obese, they just have a lot of fat on them that they're carrying around, then it would be very hard to expand the thoracic cavity fully. Also, if the patient has kyphoscoliosis, the spine will actually directly inhibit the full expansion of the thoracic cavity. So this is peripheral hypoventilation. Notice that I did not talk about the lungs or obstruction of the airways or any part of the lungs. Disruption to the airways is not considered peripheral hypoventilation. Think of peripheral hypoventilation as things from the outside preventing the full expansion of the thoracic cavity. So now let's do some questions. How would a pulmonary embolus affect the pH? So here is an alveolus, here's a capillary. Let's say the pulmonary embolism is right here, blocking the capillary. So perfusion Q will be decreased, and ventilation V will be normal. So there will be a VQ mismatch. So the partial pressure of alveolar oxygen, P big AO2, will be normal, because there's nothing wrong with ventilation or gas reaching the alveoli. But the partial pressure of arterial oxygen, P little AO2, will be decreased. So there will be an increased AA gradient. So big A to small a. This gradient will be increased. So the point is that this pulmonary embolism can actually cause hypoxemia. But the question is actually about pH. So how will this hypoxemia affect the pH? Well, whenever you get a question connecting the lungs to the pH of the blood, you should instantly think about chemoreceptors and hyperventilation or hypoventilation. So with decreased partial pressure of oxygen, the chemoreceptors, specifically the peripheral chemoreceptors, will stimulate the brainstem to increase respiration. So this patient will actually begin hyperventilating from the increased respiratory drive. So the question is, what will hyperventilation do to the pH? Well, recall the equation. CO2 plus water can react to form acid and bicarb. So with hyperventilation, the CO2 in the blood would actually decrease, and this would shift the equation to the left. So the acid content will actually decrease. And so with decreased acid in the blood, what would happen to the pH? It would increase, becoming alkalotic. Now let's do another question. Let's say a young boy inhales a peanut that blocks off the left bronchus. what will happen to the chemoreceptors and the VQ ratio. So let's draw the lungs out here. So here's the patient's left bronchus that's been obstructed with the peanut. So no air is going into this lung. So what will happen to the chemoreceptor response and the VQ ratio? Well, starting with the VQ ratio, we can see that the alveoli here are being poorly ventilated, so decreased ventilation. And the capillaries are perfused as normal, except for the hypoxic vasoconstriction that will occur. In other words, the ventilation to perfusion ratio is significantly altered, resulting in hypoxemia. The hypoxemia will stimulate the peripheral chemoreceptors, which will then increase respiratory rate. Now, what if we said that this patient did not inhale a peanut, but instead suffered from severe kyphoscoliosis? Then what would we say that this child's problem is? Well, this patient would be unable to fully inhale, so they will essentially have a restrictive lung pathology. The point is that this patient would actually have a peripheral hypoventilation problem, not a VQ mismatch. So the problem is a little bit different. However, the patient would still have hypoxemia, which would then stimulate the peripheral chemoreceptors, which would then increase the respiratory rate. Increased respiratory rate with short, shallow breaths is common in patients with severe restrictive pathology. As a review, if this patient had a neurological problem that prevented adequate breathing, this would be considered central hypoventilation. So now let's talk about bronchodilation and bronchoconstriction. Now these are the high-yield things you need to know about bronchodilation and bronchoconstriction. First, the constrictors are leukotrienes and stimulation of the M3 receptors, which are parasympathetic receptors. These will cause bronchoconstriction. Now the dilators are prostaglandins and anything that stimulates the beta-2 receptors, which are sympathetic receptors. So let's just draw this out briefly. So let's start with the arachidonic acid pathway. So basically, what is relevant is to know that arachidonic acid can undergo modification via cyclooxygenase enzymes, including COX-1 or COX-2, to become prostaglandins. And recall from the last slide that prostaglandins dilate. Arachidonic acid can also undergo modification via an enzyme called 5-lipoxygenase. And compounds that undergo this pathway become leukotrienes. And recall that leukotrienes will cause bronchoconstriction. And just imagine that in the body there's a balance between the leukotrienes and the prostaglandins. Now there are 3 relevant drugs that can alter this constriction and dilation balance between the leukotrienes and the prostaglandins. So first we'll talk about NSAIDs, and then we'll talk about Xolutin and the Leucast drugs, including Montelukast and Zafirlukast. So NSAIDs will act by inhibiting the COX enzymes, which will decrease the amount of prostaglandins. Therefore, the leukotriene pathway will dominate and you will get a higher concentration of bronchoconstrictors. So you'll get bronchoconstriction overall. And this can lead to bronchospasms. You can get asthmatic-like symptoms such as wheezing or shortness of breath. Xolutin works in just the opposite direction. It actually blocks the production of leukotrienes by inhibiting 5-lipoxygenase, and thereby decreasing the number of leukotrienes and increasing the number of prostaglandins. This will lead to bronchodilation. Finally, Montelukast and Zafirlukast will block the leukotrienes from binding to their receptors, thereby decreasing their effect and causing a relative increase in prostaglandins, thereby increasing bronchodilation. So in review, you can imagine that you need to be careful with NSAIDs because they may actually induce asthmatic-like symptoms, and with certain patients who you want to bronchodilate to help with their symptoms of a pulmonary pathology, Xolutin and Montelukast and Zafirlukast can actually be quite beneficial. So now let's talk about bradykinin. Bradykinin is involved in the inflammatory process. It increases pain, causes vasodilation, and causes increased permeability to vasculature. However, it also has an effect on the lungs. So we'll draw a lung really quickly. And what it does is it causes contraction and spasm of the bronchioles. So for step 1 pulmonology purposes, all you need to know is that bradykinin comes from high molecular weight kininogen, or HMWK. So this will create bradykinin. the angiotensin converting enzyme, ACE, will actually break down bradykinin. Therefore, if a patient is taking an ACE inhibitor, which inhibits the breakdown of bradykinin, you'll get decreased breakdown and a relative increase in bradykinin, which will cause an increase in contraction and spasm of the bronchioles. So the patient can actually develop pulmonary symptoms simply by taking an ACE inhibitor. So whenever a patient's taking an ACE inhibitor, just keep in the back of your mind that they may get these pulmonary symptoms. So now let's talk quickly about the autonomic physiology you need to know for step 1. So here's a sketch of the pulmonary system. Here's a very crude sketch of the sympathetic nervous system. And the sympathetic nervous system acts on the bronchioles to dilate them via beta 2 stimulation. Let's write dilation in big letters. Now on to the parasympathetic nervous system. The parasympathetic nervous system actually acts on the M3 receptors, which cause constriction. And of course, we're referring to the bronchioles in both the sympathetic and parasympathetic situations. So you can see that medically, we can alter some of these activities to potentially aid the patient. For example, if a patient is experiencing an asthma attack, you can dilate the bronchioles by giving a beta 2 agonist such as albuterol, which will upregulate the beta 2 receptor. Or in a COPD patient, you could try to block the M3 receptors to cause a relative dilation. An example of this would be ipratropium. Now, ipratropium is called a muscarinic antagonist, M3 standing for muscarinic receptor. So now let's talk briefly about vasoconstriction and vasodilation as it relates to pulmonary vasculature. So the constrictors that you need to remember are endothelin, carbon dioxide, and calcium. And the dilators, essentially just think of nitric oxide. So let's draw this out really quick. So here's an alveolus, and here's the capillary. On the left side is constriction of the vessel, and on the right side is dilation. The constrictors of pulmonary vasculature are endothelin, CO2, and calcium. And you don't need to know a ton about endothelin, other than it's a very potent vasoconstrictor. And as you recall from the cardiovascular chapter, intracellular calcium causes constriction of smooth muscle, and CO2 causes dilation of vessels everywhere else except in the pulmonary vasculature, in which it causes vasoconstriction. So now for the dilators, mainly think of nitric oxide. What you need to remember is that if a patient has vasoconstriction of pulmonary vasculature, you should expect the levels of these constricting compounds to be high, and the dilating compound, nitric oxide, to be low. Conversely, if there is dilation of pulmonary vasculature, assume that nitric oxide is high and these constrictors are low. The only question remaining is, how do we determine if the pulmonary vasculature is dilated or constricted? The answer lies in hypoxic vasoconstriction. By the end of this lecture, you should be familiar with this concept. Just remember that hypoxic conditions cause vasoconstriction. Let's do an example to apply this. Okay, so let's say a patient has severe chronic bronchitis. And compared to normal, what would you expect to happen to the levels of nitric oxide, calcium, and endothelin, as well as the partial pressure of carbon dioxide and oxygen in this patient? So this patient has chronic bronchitis, which is a form of COPD, and COPD causes hypoxemia, so decreased PaO2. So this answers part of our question. They're going to have decreased partial pressure of oxygen, and during states of hypoxemia, there will be hypoxic vasoconstriction. So we would expect an increase in the levels of vasoconstrictors. So we'll expect increased CO2, endothelin, and calcium. And we would expect a decrease in nitric oxide, because clearly the constrictors are dominating in this state of hypoxic vasoconstriction. Now, I don't want you to think that the only things that dilate or constrict pulmonary vasculature are the things mentioned here. For example, as you recall from the cardiovascular lecture, that in times of high metabolic demand, you'll get increased levels of potassium in the blood, lactate, and acid, for example, and adenosine. And these three will dilate to increase blood flow. But I didn't want to conflate the two concepts comparing the metabolic demand versus the state of hypoxic vasoconstriction. So this is just a separate principle. I just want you to know that these things still exist, even in the pulmonary vasculature, and can alter the diameter of the pulmonary vasculature. So now let's talk about pulmonary integration. So for each pulmonology alteration, you should think of 5 things. You should think of the chemoreceptors and whether or not they get stimulated or not stimulated. Think of what happens to respiratory rate, and then think about cerebral and pulmonary circulation. Does anything change in that way? And then think of the alveoli. Some of the things that you want to think about with regards to the alveoli is dead space within the alveoli, think of VQ ratios, and think of the AA gradient. Lastly, think about blood content. Some examples you're going to want to think about are oxygen content, the pH, the partial pressure of oxygen, and several other things. But mainly just, if you can think of these 5 things with each pulmonary physiology question, you will do quite well. Okay, so let's apply this knowledge. So let's say a patient has obstructive sleep apnea. What alterations will occur? Okay, so this patient has obstructive sleep apnea. So what will happen to these different aspects of the pulmonary physiology? So in obstructive sleep apnea, the patient fails to inhale properly due to relaxation and collapse of the muscles in the upper airway. So this would decrease the ventilation. So with reference to the alveoli, you can see that the patient would actually have a VQ mismatch. As far as the blood content goes, they're going to have decreased arterial pressure of oxygen and increased partial pressure of carbon dioxide. Now with increased partial pressure of carbon dioxide, the cerebral vasculature would actually dilate. So I will draw an up arrow to indicate cerebral vasodilation. And as far as the pulmonary vasculature is concerned, it would do just the opposite, because CO2 has an opposite effect in both of these regions. And the increased CO2 would actually stimulate the central and peripheral chemoreceptors, and so respiratory rate would also increase. So let's do another example. Let's say a patient is hyperventilating from a panic attack. What alterations will occur? So if a patient was hyperventilating, we can assume that the partial pressure of carbon dioxide has decreased, and their partial pressure of oxygen probably hasn't changed a lot. It may have increased a little bit, but not nearly as much as the carbon dioxide has decreased. And the decreased CO2 would cause a relative constriction of the cerebral vasculature, and so you would get decreased cerebral perfusion in this patient, and this can give them symptoms of dizziness or even syncope. The pulmonary vasculature would do just the opposite and experience a relative dilation. The increase in oxygen and decrease in carbon dioxide would cause decreased stimulation of the peripheral chemoreceptors. However, respiration would not decrease. After all, that's the original problem. So ventilation would remain high. So let's do another question. Let's say a patient has severe COPD. What alterations can occur in this patient? Okay, so this patient has COPD. And in a patient with severe COPD, you can assume that they are hypoxemic. So decreased partial pressure of arterial oxygen, and that the partial pressure of CO2 would be increased as well. This increased CO2 would cause increased acid content, and together they would dilate the cerebral vasculature. And the high CO2 with the low oxygen would actually cause constriction of the pulmonary vasculature. As discussed previously, hypoxemic vasoconstriction would cause more blood to flow to well-ventilated regions of the lung. So let's talk about dead space for a moment. So whenever I talk about alveoli with reference to this diagram, it's just important to think of what's happening at the alveolar level. So this is why things like AA gradient are relevant, VQ mismatch is relevant, and then we can actually even talk about dead space. And dead space is what I want to focus on at this moment. So the increased blood flow to the more ventilated regions of the lung would actually cause dead space to decrease. This may seem counterintuitive, but if we compare two alveoli, it will make sense. So I'm going to erase this down here. We'll draw two alveoli. The left alveolus is poorly ventilated, so the capillary is constricted. On the right is an alveolus that is well ventilated, so there will be a relative increase in blood flow to this alveolus. The vasoconstriction of the left capillary would increase dead space in this poorly ventilated alveolus. So I'll just write increase dead space, because less of the gas that enters this alveolus will be able to participate in gas exchange. However, the well-ventilated alveolus would send more gas to the blood than normal, simply due to the increased blood flow to this region. So the dead space in these ventilated regions would actually decrease. So I'll write decrease ds. So the overall physiologic dead space in these patients would actually decrease on account of this decreased dead space. So as for the chemoreceptors, these would be stimulated due to the decreased oxygen and increased CO2. So that means that respiration will be stimulated. So as a review, for many pulmonary physiology questions, quickly thinking about each of these concepts, chemoreceptors, respiration, cerebral and pulmonary vasculature, the blood content, and by extension, the pH, as well as what's happening on the alveolar level, will help tremendously, and you will rock step 1. And that concludes this section.